activities has been completed as agreed. I've had a conversation with NHSEI as part of the process as well. The BAF action plan has been developed. It's being monitored through ISPG and reported to QGC, of which we had a discussion this month.
Okay, thank you very much. I'm sure that's fine. Staff, we're still with you, Sharon. The staff vlog, would you like to introduce it, and then we'll go to this? I believe there's a video component to it, so
I would indeed
like to take over this bit of it. That would be fine. Thank you.
Thank you. So the chosen topic for this month's board story is winter, a time at which we face additional pressure in both our front door and our back door in managing discharges safely. This year, clearly, it's been made even more difficult with the COVID pandemic. One team in the hospital who help us every day, 24 hours a day, manage this is our site team. And I'm delighted to introduce Priya, a site practitioner, to share her story with the board. Thank you, Kieran.
Thank you, Sharon, so much for asking me to tell my story to the board today. I'm really privileged and honoured to be here and talk about myself and my role in NGH. My name is Krishna Priya, but everyone calls me Priya because it's shorter and sweeter, I think. So I work in a clinical site team as a clinical site manager. I started in this trust in February 2020, and so basically walked into the pandemic. By background, I'm a nurse, and I was working in a different trust as a surgical nurse, and then I was a manager for a surgical assessment unit, then moved into clinical site management. So being a clinical site manager, my primary role is to make sure patients' safety is achieved in terms of getting them to the right place in the right time, and we have to balance between the emergency and elective demand of the trust. And I see myself as a bridge between the clinical teams and the operational team. In our day-to-day activities, how we work is we belong to every team in the trust, basically. So we work with nurses, we work with medics, we work with multidisciplinary team. We probably don't know all the answers, but what we need to do is to correlate and work alongside different teams to put the operational activity together on a day-to-day basis. It's an already challenging job, and the added challenge this year that we are in a pandemic. So everyone is affected because of the pandemic. There's lots of demand from public to keep everybody safe in terms of infection control and to look after each other, to make sure that we put patients in the right place in the right time, ensuring their safety. There's so much of responsibility on us. Going into the winter, we have added pressure in terms of A&E attendances. At the same time, there is so much of risk around having infection control issues like flu, norovirus, and you're bound to see more respiratory illnesses coming into hospital. So it's an added pressure on our team and everybody else in the trust to maintain the safety, maintain the flow, to keep the front door and back door functioning at the same time, to have the balance of safety and quality in patient care. I think what is most important is planning, being proactive rather than reactive. So we think about tomorrow and the day after rather than just today, because what you want is to place patients in the right place in the right time. That is so crucial to get them the right treatment. So I see that as a core of my job. And everything that I do, what I see is my actions affect a patient at the end of the day. So, and one thing I've learned in my job is act. So I say action changes things. So act. The worst thing is that you don't do anything about it. People may ring you with issues. You may have patients that's not placed in the right place. You may meet someone in the corridor having an issue. The worst thing that you can do is not to do anything about it. You may not be the right person, but my challenge is to make sure that I get them to the right help, point them to the right direction and in the right time. But I should say that, you know, with the massive support from our nursing team, the management and the operational team, we have been able to achieve it so far, and I'm really hopeful that going forward we will be able to maintain the standard of care. Everyone in this hospital have the core of their work is patient safety and maintaining the quality in the patient care. So keeping the ratio of staffing, making sure everybody who will work with you is being looked after, and eventually that will pay towards the patient care and the quality of care. You got to look after your staff and your colleagues to make sure that you are kind, you are honest, you have the authenticity in your actions. So it is really important that we look after each other and make sure that you have the standards kept in the challenging times. I'm really looking forward for next year. We've learned so much this year, and we are still learning from our mistakes, from the new guidelines and knowledge coming out about, you know, different things. We learning every day. But one thing that I'll make sure, and I think every one of us, you know, in NGH should make sure, is to look after yourself, because we forget it. And I've done it several times, and one thing I've learned is unless you keep your health and your mental well-being up, you won't be able to perform well in your job. I have failed at times in looking after myself. I've got 2 kids and they are young, so I have had occasions where I was really pressurized from my personal life, and it has affected my professional life. But it's about keeping that balance between personal and professional life, because like I said earlier, we want the best for our patients. So it is crucial to keep your health, mental well-being. It's about being open. If you have a problem, talk to your colleagues, talk to your manager. Everybody is so approachable and helpful. So that will be something that I will definitely suggest to my team members and everybody else out there, that talk to people, talk about your problem, get help in the right time, look after yourself so that you're able to perform well at work. Despite all the challenges that we have, we were able to work together, and I'm really grateful for all the support and help that everyone at NGH gives me and my team.
Okay, thank you very much for that. That was pretty good stuff, really. And you all know that as we move into the group model, the objectives and mission and values all talk about putting equal balance on staff and patients. Because if you get the staff bit right, you get the patient bit right. And I know that the hospital has done a lot to provide support. I think there was an award for the SOS cafe, and I know Mark has put together, with others, have put together a lot of services, things that would help to support staff. So the good news is they can see the light at the end of the tunnel as vaccines begin to appear. The bad news is not yet. And it's going to be a pretty difficult few months as we go forward. Anybody got any comments on that video from staff? No? Okay.
I did, Alan.
Sorry, Simon, couldn't see it.
So firstly, I just wanted to say I love that. I thought that was absolutely brilliant. When I started out as a general manager, which feels like an unfeasibly long time ago, the thing that everybody told me was that the place that you go to learn where a hospital really functions is go and spend some time with the site team, because they're the ones who will actually, A, they've got your back when you're somebody on call, and B, if anything goes down in a hospital, they will know how to respond to it. And I thought Priya was a fantastic advert for everything that is good about a site team. And so I just wanted to say thank you for her for sharing her story. And I would encourage everybody on the board, as and when we come out of the COVID penumbra that we find ourselves in, to go and spend some time with the site team, because you learn more in a short space of time than you earn in any other visit that you will ever do. I promise you that. Many of us have spent many happy days with site teams in our jobs. So do that. And the second thing I wanted to say was what a great advocate for our people plan. And I quite felt that she was probably after Mark's job by the way she was able to talk so eloquently about health and well-being. Because the site teams see that at the front line. It's not, you know, if there are people under stress or in distress, feeling happy, sad, or whatever, the site teams see it. So they're often perhaps the best barometer of the emotional well-being of a hospital. And so I just wanted to publicly thank Priya for being so honest, so frank, and being such a brilliant representative for what a site team can or should be.
Okay, I've finally found a hands up screen, so I can now see who you've got. So, Mark, would you like to defend your job?
Yes, thank you. In public, I'd like to say I'm very much enjoying my role and would like to keep it. So, but because I would nowhere near be as good as Priya is for site management, most definitely. So, I just wanted to say we shared this at the People Committee earlier this week. I think it's Monday, in relation to the health and wellbeing programme that we currently have in situ. And I'm mindful that a number of colleagues may have seen it, but I just wondered if it was worth, after this meeting, me circulating it to all board members so we can see the full extent of the package of support that we've got in place at the moment, which actually Priya did a much better job of articulating than I could ever do. So I'll remember that for the next few group briefings as to who to bring in.
Okay, thanks, Mark. And I think the answer to your question is yes. Debbie.
Thanks, Chair. Again, thank you to Priya. She did a really good job with that log. I think being a site manager is probably one of the most difficult jobs in an organisation. I was a site manager in a previous life, so I can speak with that experience. And they do a fantastic job every day. It is a constant juggling act. And I just want to thank her for her openness in the video. Thank you.
Okay. Thanks, Debbie. Carol.
Yeah, very briefly. I spend an awful part of my life up in the site team. They are my core team that I rely on for everything. Priya, I have to say, has been a fantastic appointment. She's only been with us a fairly short time, but the professionalism she brings into the job has been absolutely outstanding. And as you say, you can see it from the presentation and from her video, but she's been fantastic. And I only echo what Simon has said. If you want to see how the hospital works, come and join the site team for a day. You'll learn an awful lot.
Okay, if you want to know how a hospital works, go and see the site team, control room stuff, whatever else we call it in different places. Anyway, there's obviously an open invitation there for anybody who wants to understand how it works. Okay, thanks very much. Yeah, Jill, your microphone's on. You want to say something?
No, sorry.
No, okay. Okay, fine. Thanks for that, and thank Priya for us. I mean, it's good to be reminded of all that stuff all the time. Chairman's report. I don't have very much on this one, really. I mean, I've already sort of mentioned in passing the COVID pressures. Clearly, there is a light at the end of the tunnel with vaccines, and NGH has a particular role in the county in the distribution of those vaccines, difficult as it will be through the cold supply chain. But we will be talking about that in other places, and that will be crucial in providing the level of vaccination across the county. Obviously, That's not going to happen immediately, and whilst our staff will be priorities, as will care homes and elderly, everybody knows that. Around about 11 o'clock this morning, you get told which tier we're in, and that will obviously have an impact on people's sense of well-being. So we do see an end to this, but we just don't see it yet, and it looks like being a very difficult depth of winter, December and January, for our hospitals. The only other thing to say is the interviews for the group posts and the hospital chief exec posts are occurring in the week beginning the 14th of December, and so they will have occurred before our next board meeting, and those appointments, and everybody knows the interview panels and the processes were in place for that. And I'm told by the recruitment consultants that we have an excellent field right across the board. Some posts slightly more excellent than others, but nevertheless, an excellent field with lots of interest. There's obviously a lot of people looking at the development of the group model and thinking, I'd like to come and work there. And finally, we have an integrated care system or a healthcare partnership away day in December, where we'll be resetting the objectives and the way of working for that organisation. And we've talked about that a lot. We'll talk about it again in our January board, but just to say that there is a significant opportunity to re-energise and reboot the healthcare partnership work through December with its new chairman. So that's me finished. Anything on that? No hands, no. Simon.
Thanks, Alan. So just continuing as I start my report with the theme of healthcare partnership and the work that we're doing with them. So you'll see in the first section of my report, I talked about the group vision, mission and values, and Alan and I took our engagement work out to the healthcare partnership last week. And I have to say it was really well received. We got a lot of comments about how people want us to be and what they're looking forward to as a part of us being a group. And I know that they're keen to continue that conversation, particularly as we head towards an ICS. That visioning workshop that Alan talked about is really important, actually, because what that sets up is not just a kind of governance discussion, because a lot of our discussions to date have focused on how do we want to structure the ICS, but I think a far more interesting and important question is what do we want the ICS to be used for? What are the big problems that we want to help solve by having this thing? It shouldn't be just about moving organisational deck chairs around. It should be about us helping create better care for our residents over the longer term. I was struck recently by stories from another system where collectively, as a result of the work that they'd done, they decided to invest in smoking cessation, because from their point of view as a whole system, that was the highest priority. And for me, that's what the ICS is there to do. What are our highest priorities in health and care, and how do we best address them? And our part in that is a really important one. And I think everybody welcomed the offer that we had made to help shape our vision, mission and values. And I know that they're looking forward to helping us shape what we do next. On COVID, I just want to say a few things, really. The first is that people have been doing phenomenally well. And you're going to hear about that during the board conversations today. I have always said that the second wave would be harder than the first because you're spinning 3 plates as opposed to 1. You're spinning a COVID plate, and hopefully we are now at near the top of wave 2, but you know, it's still too close to call which way the numbers will go. We're continuing to spin the elective recovery plate, and that you're going to hear about as board directors take you through how we're doing on that today. And we're dealing with the rise in winter pressures that normally come at this time of year. Wave 2 was always going to be so much more of a challenge for those reasons than wave 1. And added to that, we've got the additional challenge of playing a lead part in helping implement the vaccine. It's changing, and it's far too early to talk concretely about that. I just want to say two things. The first is that we will be playing a leading role, and one of our own, Kirsty Palmer, will be taking a very leading role, and I want to thank him in advance for stepping up to take that leadership role across the county, because you couldn't imagine a much more important responsibility to our public than helping lead this work. So I know we all will wish him very well in that task, which will be lasting probably over the next few months, I think. I say a few months because, to be honest, as we sit here now, I don't know how long all of this is going to take. We're still very much in the process of mobilising the arrangements, and that's where our focus will fairly rapidly turn. I can't say anything more about it now because we don't have that detail, but we will be heart and centre of the vaccination effort for our local population. And many colleagues, not just Chris, will be involved in that from across the group. And I think that demonstrates what we can bring to big problems that we have when we work together. And so thank you to everybody who will be supporting Chris in that endeavour. To say also that this is a time for thank yous. So firstly, I'd like to thank Phil. Being the role of a finance director is a thankless one. Everybody's a critic, nobody's friend, often having to plough quite a lonely furrow. And so you first of all just need to thank your FDs for keeping you safe, because that's their first job, but it's one that often gets unremarked and seems invisible. But I want to pay tribute to, I think, three very visible artifacts that will, I think, be the legacy that Phil will leave us, which will be quite visible. So we wouldn't be contemplating next year having a new ITU if it hadn't been for the work that you did, Phil. We wouldn't be contemplating opening a children's ED at the end of December if your efforts hadn't been as good as they were, and we wouldn't be opening a new front entrance if you hadn't been part of those conversations and navigating some quite tricky contractual issues over the line. So I think it's really important to recognise those really important contributions for me publicly on behalf of us all, to say thank you for that. Another thank you, but also a welcome. I guess one of the sincerest tributes that you can pay any director when they depart is what's the quality of the person who can step into their place. And I'm very fortunate, we are very fortunate to have somebody of the standing of Bola to come join our discussions. So you're very, very welcome, Bola, to these discussions. We all have absolute confidence that you can do the job. In fact, Phil has already told me how much of the job you already do, really. So I know that you will really help our discussions, and that, you know, as I said, the fact that you're there is another real tribute to you, Phil. So thank you for that. So with that, I will end my comments, and happy to take any questions.
Any questions, comments on Simon? No, no hands up. I don't see any. Nope. Debbie, it's a litany of chief exec reports. Is that the plural now? A litany? Maybe it isn't. Anyway, Debbie, you're on.
Thank you very much, Chair. So I just want to pull out a few key points from my board report. And I think it's important to start by saying, as we approach winter and the second wave of the pandemic, I'd really like to start by thanking our staff for not only their unwavering support and dedication, but hard work in continuing to care for our patients every day. It's a really strange time, isn't it, for the NHS at the moment? And of course, we are not excluded from that. So work within our hospital and also how we go about things in our own personal lives is very, very different now compared to how it was at the start of last year. So we can't underestimate the impact of COVID. And what we are seeing is people reacting differently to the pressure of the pandemic, and that in itself does present us with some challenges. Health and well-being, we've spoken about a lot already this morning, continues to be very much at the forefront of all of our actions, and it is very important that we continue to look after our staff but also each other as we go through winter. So I've highlighted in my report how we continue to provide support to our staff when things are difficult either at work or at home. I've highlighted the special days also that we've celebrated in October, including Black History Month, where we had many events and also an online webinar involving our staff. My favourite special moment of the month was our Best Possible Care Awards. And it was a very different type of event this year, but it was also welcomed and enjoyed by an awful lot of our staff. And in fact, they're still talking about it today in terms of the shock of winning and how proud they felt to be nominated or shortlisted. So it was quite a humbling week, and one which certainly grounded me in the reality of healthcare during a pandemic. So we will continue with our looking after our staff over the coming months, and we've got some special thank you events, gifts and personal wellbeing support will continue. With regards to COVID, since I wrote my report last week, the numbers of COVID in the hospital have increased again, and today we have 90 inpatients. Despite the hospital being busy though, due to the emergency care pressures, we are continuing with our routine elective activity. So that's our phase 3 activity. But unfortunately, on some occasions, certainly over the last few weeks, we've had to support other hospitals with critical care capacity when they've run out of critical care capacity, and also starting to see an increase in our own COVID activity. That's meant that we have had to postpone some routine operations and outpatients. And I'd really like to say at this point that I am truly, truly sorry to our patients that the decision that we've taken to postpone has affected. But my and our main priority in this hospital at the moment is the safety, and we must continue to put that above all else. So I think everybody is aware that an important part of our recovery is the reduction in patients who've waited over 62 days to be treated. And that's on a cancer pathway. And I'm really pleased to let you know that the number of patients has decreased again, and we continue to focus on the delivery of that key quality and performance target. And thank you very much to the teams who are working on this. It's definitely going in the right direction. As well as elective activity, we continue to do fantastic things for our patients and staff, many outlined in my report, but one that I would like to highlight is Remembrance Street. And this is where our staff turned Hospital Street, the main street through the organisation, into a walkway of poppies earlier this month. It was a true team effort by our staff, and actually local children as well got involved in knitting, crocheting and colouring in poppies. It was really lovely to see. Moving on to estates, we have got a lot to be excited about in the next 12 months, not least our developments. They're noted in my report, and despite some unexpected challenges, we are generally making good progress with our 3 largest estate projects, which Simon has mentioned earlier. So I will stop there, and I'm happy to take any questions.
Okay, anything on any of that? That's a 50% rise in inpatients in a week, Debbie. That's quite a significant bulge as we come to the end of lockdown. And we know there's a 2 to 3 week lag in these things, but nevertheless, that's quite a scary number. I think most hospitals were beginning to see a decline, so obviously that's quite worrying. Anything else at all, anybody? Oh yes, Tom.
Yeah, Alan, we discussed this at QGC briefly last week, but just and Debbie and her team gave a response, but I felt it was worth airing here as well, just around the flu vaccine. I mean, historically, we're very good at ensuring our staff uptake the flu vaccine. And I see that there's already been an increase from the 51% reported last week to 57% this week. But just Debbie may just want to comment on the actions the trust are taking to try and ensure that we get to our usual level of compliance with flu vaccination.
Yeah, thanks, Tom. Really good point. So flu vaccination, really important for our staff to have that, to not only protect themselves, but our patients as well. So originally we had all of our staff go to occupational health to have their flu jabs, and we did that in alphabetical order of surnames. We've finished that now. The uptake wasn't as good as we expected, so we have now started to have our vaccinators go out to the areas to address the staff that haven't had their jabs, and we've started to see quite an increase in our compliance over the last week by doing that. Thanks,
Debbie. Of course, there is a requirement to have the flu jab well ahead of your COVID jab. 3 weeks, I think it was a month, but I think it's 3 weeks. So clearly there is a significant pressure to get the staff numbers up by pretty early in December, which is not very far away. Where am I now? John.
I think also one of the issues with the flu jab is so many people working from home, and clearly that makes it difficult to vaccinate them. I don't think there's a lot we can do about that unless they go to their GP.
Yeah, you're right, John. But saying that, we've had quite a lot of staff who are working from home still come in to have their jab, so they can still come in, they can still park for free, as well as all the other staff. So I don't think there's any excuse there, really.
Good, thank you.
Yeah. I seem to remember not long ago going in to have my flu jab. So it's not that scary a pastime. Anybody else at all? No? Good. Okay, so moving straight on, Debbie, to the, yeah? Somebody say something? No? Moving straight on to the integrated performance report. This is your show. You're running it and you'll bring your colleagues in as you see fit. So over to you.
Thank you very much. So we're going to note performance in this section of the agenda, and then we will go through activity in the reset part of the agenda. I'm going to start, and then I will hand over to each of the directors to give their updates. So we're making some progress with our performance targets, especially cancer and diagnostics. I still remain concerned about our 52-week position, as recovery is not as planned. And this is because we've had some patients coming onto the treatment list that we didn't originally account for. So I am concerned about our treatment list, and up to the last few weeks, it has continued to grow. It has now started to decrease. I'm concerned about the validation of that list and the accuracy that then brings. And to that end, I will be seeking some additional external views of our treatment list and our processes around our patient treatment list. I'm also worried at the moment around sickness absence of our staff. As we go into a difficult winter, I would expect that to start to rise, and that then stops our ability or decreases our ability to increase our internal capacity, so put more beds in place. And as we progress further into the winter, then that becomes a challenge because we will need more bedded capacity. And we'll talk about that a little bit later this morning when we hear about the winter plan. As I said earlier, ways of working in the NHS is now very different. And we mustn't forget that the NHS has never had to work through such a major pandemic. It is very, very different. Routine activity has been quite slow to restart. Many patients are still afraid to come in for their operations, and processes are much slower. And some of our theatres now being in use for other procedures such as endoscopy. The recovery of our elective work will continue to be slow, but we must maintain safety, and we do that. So I'm now going to hand over to each executive director to go through their salient points. And we're going to start off with the national performance targets. So Carl, please.
Lovely. Thank you, Debbie. Let's start with A&E first. So performance was at 78.3% for October, which is 2.48% down on September's figure. However, that is 5% higher than it was this time last year, which, given the COVID challenge, I think is really worth noting. We saw 11,793 patients, so just under 12,000 attendances, which is lower than this time last year. However, our admissions are at 97% of last year's figures, so we are admitting more patients as the acuity rises. And as we've seen over the last few weeks, that a big proportion of those patients are starting to be COVID positive. Our ambulance attendances continue to rise. We saw just under 3,000 ambulances arrivals in October. There is a national focus on ambulance handover times to ensure that the crews are back on the road as soon as possible. And obviously we absolutely support that. But I am pleased to report that we are one of the best in class with regards to our handover times. And this was noted by NHSEI this week around our performance around that particular target. I have to be very clear, for our performance is not where I wanted to be at this present time, but I also have to acknowledge that we are working in a very different way to how we did last year. As we test every patient that comes into the hospital for COVID, we are testing 24/7 our patients. So consequently, we do not move patients to an assessment unit or a base ward bed until they've had their swab results. Once that test is complete, the patient is then moved obviously into a red COVID stream or a green COVID stream, or if the patient's been exposed, into an amber COVID stream. This adds delay to the process, but from what I feel is it builds in safety for the patient being admitted, but also builds in safety for the fellow patients that are on the ward where the patient is being admitted to. So that is the reason why we're seeing the slowdown of our patients through A&E, but we are ensuring that we are offloading ambulances in a timely fashion. We've gone live with Think 111, and we're already booking our patients into our SDEC area. And those not familiar with the acronym, that's a same-day emergency care area, and thus avoiding our A&E department. In December, our SDEC and our frailty unit will be moving to a new purpose-developed area closer to ED, and which will give us a significantly bigger footprint to allow a greater cohort of patients to be seen. Our bed occupancy is high, it's at 94%, but we still have 2 wards closed with 48 beds that are in our back pocket. They're not included in the calculation, but will give us a buffer as we move into our COVID peak in the next week and into deeper into winter. Stranded and super stranded patients have risen slightly again in October, but remain well below the same period last year. However, I have initiated a piece of work as part of our discharge programme, which is changing the way the discharge team work, and we've also introduced a winter task force of 4 doctors, a nurse and a pharmacist to support discharges 7 days a week. I'm also the exec lead for the ICANN discharge programme, and I will be incorporating any of the early wins into the actions in the coming months. We have seen a fall in stranded numbers in November, and our figures currently sit at, certainly for 21 days, at 13.1%, and that's against a requested target by NHSEI of 12% over the winter period. So we're only 1.1% above what we've been asked to achieve, but obviously what I want to do is get us well below, and ideally I'd love to get us into single figures. If I take us then on to cancer performance, which Debbie's alluded to, it's one area that I'm really starting to be pleased about. We've seen some very good progress in improving the service we provide to our patients. The activity you have in front of you relates to September, so this is quite old data now, at the time of switching back services on following the COVID phase 1. With support from the medical director and the lead cancer clinician, the 3 of us have met as a triumvirate with each cancer site lead to discuss the issues faced and what we can do to help them, but also set out our expectations. The meetings have been well received, and we've had a number of simple requests frustrations actioned, and we're meeting again with the teams in the next couple of weeks. As we look forward to November, I'm already seeing that we're now meeting the 2-week wait cancer target. We are achieving 31 days and the 28-day faster diagnosis target. So that's all really positive. Our legacy patients have fallen from 150 to 57 as of this week, and the numbers of patients waiting greater than 104 days has fallen from 69 to 8. Still much more work to do. I don't want any patients waiting over 104 days, and I don't want any patients in legacy, but we've made a big inroad here. I'm really pleased with the impact that the teams have made as we've made this our #1 priority. And our teams are introducing more one-stop clinics and endeavouring to get our patients seen within 7 days to hit the targets. If I move on briefly to elective care and RTT, the median wait in June was 16.5 weeks for the first appointment. This has continued to fall each month and now sits at 9.5 weeks for October, which is a real improvement. We have had an external review of our patient tracking list, our PTL, and that's been completed by the National Elective Care team, and who've reported back to us on our national performance. We are ranked #2 out of all acute hospitals, which is around 135 acute hospitals, for the validation of our PTL. We're rated at 16th out of 135 for our data quality, but unfortunately we're rated at 122nd for our overall capacity issues. So bottom line is we have really good processes for managing our waiting list. The quality of our patient tracking list and our waiting list is very good, but fundamentally at the moment we lack the necessary capacity to meet the demand, and that's obviously a clear focus for me over the coming months. We are currently in the process of validating our entire waiting list as part of the national ask, and this will remove further patients from the list that no longer wish to be seen, and this is being supported to us by a company called Healthcare Communications, who are writing electronically by letter, by email and by text to every patient on our list to check whether they want to be seen given the COVID situation, have their symptoms relayed and don't need to be seen anymore, or have their symptoms got worse and want to be seen urgently. Those letters and information are going out at the moment, and then I'm just waiting for the feedback from those, and then we'll be starting a clinical validation of that information when it comes back. The one area which Debbie has already alluded to where I am disappointed is our 52-week position, which had risen to 654 in October against a forecast of 124. This is disappointing, and I have to acknowledge that we did not factor in enough tip-ins into our modelling. So as fast as we cleared the 52-week cases, more were dropping in. I have to take full responsibility for that. This was further compounded by us losing theatres to ITU pods as our COVID numbers have expanded. And we currently have 2 pods open at the moment, which takes 2 theatres out. And we also have 2 theatres that we're currently using as an endoscopy unit. We have seen a significant scaling back of the capacity on offer from the 3 shires as they concentrate on their own activity. So again, that is impacting on the amount of elective work that we can do. However, on a positive note, we have seen a fall in the 52-week patients that are waiting over the last 3 weeks, and as of yesterday it sits at 502 this week. Finally, our diagnostic performance continues to improve. Previous month it was at 46%, September it was at 74%, and I expect it when the figures come in finally in October to be in the 80s for October. All modalities are at maximum capacity, and certainly most are working at greater than 100% of last year's activity levels as we continue to recover the position. This has been supplemented by the independent sector, and MRI and CT are now booking back within 6 weeks, and it's anticipated we'll be back delivering the 99% target by the end of the year. I will stop there before moving on to reset. If anyone wants to, if I want to take any questions, Debbie.
Thanks, Carl. So we'll do reset under the next agenda item, and I'd now just like to hand over to Phil Bradley, please, to talk through finance.
Can you just pause for a minute, John Arch? John has his hand up, Debbie. John, and then Denise. And then
Thanks, couple of questions, if I may. First of all, endoscopy. We know that's been a concern. What have we done to increase capacity? I heard you say about the theatres, but clearly that's not a long-term solution.
Yeah, John, I mean, you will see the figures in the thing. So we're performing at over 100% of our activity pre-COVID. But that is a combination of using 2 theatres for endoscopy. We're insourcing, so we have companies coming in to do endoscopy for us at the weekends. And there's a lot of work going through there. We've also done some work down at the 3 Shires as well. And we've got a new endoscopy unit opening in Daintree in January as well to support the situation. Where I'd like to get to, obviously, is to get our 2 theatres back. And at the moment, we're exploring whether we could potentially drop in a Vanguard mobile unit to also support the position going forward.
Good, thank you. And then secondly, we've got 2 wards closed. I think you said about 48 beds.
Yes.
We may well need those during the winter period. How are we going to staff those, given that our staff are currently working absolutely to their limits and we don't have spare staff sitting around? How are we going to safely staff those wards?
Well,
I think it would probably be good to just ask Sharon that question.
Thank you, Debbie. So absolutely, John, that's a really good question, and a question that we ask ourselves every day, because maintaining our patient safety is our absolute key priority. We have a centralised staffing hub now that manages the nursing and care worker staff within the organisation. If we become under increasing pressure, we do our risk assessments, and we're pulling back nurse specialists, practice educators, individuals with a registration to support patient care in clinical areas.
Thanks, Sharon.
Can we go to Denise? And I did see Stuart waving in a more physical manner. Stuart, do you want to do first, and then we'll come to Denise, because I suspect yours is relevant.
Yeah, I'm technology problems this morning, so I'm really hoping you can hear me.
Yes.
It's good. Yeah, John, just to add to Carl's comments about capacity, the reason the original 2 theatres aren't in use is because the ventilation system isn't capable to meet the new guidance around COVID. We've got contractors on board, and we hope to have a new ventilation system installed by year end. But yeah, it's a sizable project. It's £750,000 worth of spend. But we're well on way with that. So the sooner we get that developed, the sooner it will help ease the pressure as well.
Thank you.
Okay, thanks, Stuart. David, sorry, Denise, have you taken your hand down?
My query was the same as John's. How are we going to staff the wards? Yeah.
Okay, David and then Rachel. David.
Hello. Yep. Yeah, sorry. Carl did mention the 3 Shires during his presentation, and in our Finance and Performance Committee yesterday, we did raise a challenge around the 3 Shires, and particularly the risk to performance and delivery of patient care to the hospital as a whole, should we lose access to the 3 Shires. And we weren't really clear about exactly what the level of that impact would be, and when indeed we could lose access to the 3 Shires, which apparently is playing a more and more significant role in delivery of care to our patients.
One for me, I think, in my other role.
Indeed, Simon.
That wasn't being looked for all that. So the short answer is, I can't say too much in a public board session, but suffice it to say discussions are ongoing to help get to a place where the NHS has access to the volumes of work that it wishes to do in the private sector in Q4. And those discussions are highly live at the moment. There is a recognition that we need to reach a positive outcome on them. And that is work I am doing, as I say, in another place at the moment. So it's a really good point, David, and one that is not just an issue for us, but in actual fact, wearing my other hat, an issue that everybody is having to deal with right across the country. And hopefully we will have some positive news on that in the not too distant future.
Thank you, Simon.
Simon. Rachel.
Yeah, quick question for Debbie or Carl in terms of cancer waiting times. I think the figures are obviously, it's good that we've had the reduction from July, but given that we know a number of people put off going to their GP post COVID-1, are we then expecting those 62 days and 104-day waits to go up? And if so, what are we doing about it? Or what can we do about it? And second question is, are we managing to keep in contact with those people who are on those waiting lists regularly? It can be a very scary and lonely place.
Yeah, thanks, Rachel. So I think the first point is we're waiting. The GP referrals coming back into the organisation are more or less where they were last year. So we're seeing those potential cancer patients coming through. We are now achieving the 2-week wait, and that's the key to this, really, making sure that these patients get in and seen quickly. So that's really good. So yes, they're coming back in. Yes, I expect that they will continue to. Yes, we are seeing them in a timely manner, and we will continue to do that. In terms of keeping in touch, our clinical nurse specialists are working quite differently now, and they are in regular contact with patients.
Okay, thank you. Jill.
Thank you, Chair. So I wanted to say what an amazing job everybody's doing this juggling trick that we talk about, looking after patients with COVID, the non-COVID patient flow, and managing the urgent care front door. So I think it's great to have some kind of good news and progress at this point in time, given the context in which we're working. I was pleased to hear, Carl, that we are in contact with patients on the waiting list through healthcare communications, I think you said, which is fabulous. But I was just a bit concerned that this is a big responsibility for patients to say, yes, I need to be seen urgently because I don't feel as well as I did. Because given what we learned in COVID-1, patients may not want to bother us because they know we're busy and they hear the news, etc. So have we got a clinical eye on the kind of presentations that patients have on the waiting list, and looking at perhaps where some patients would take priority over others outside of the cancer waiting list?
So yeah, absolutely. I mean, for the long waiters, if I talk about the 52 weeks ones as a perfect example, every one of those has had a harm review completed to make sure that their condition has not got any worse, and that we have not created any harm for them while they've been waiting for their surgery or their treatment. As patients trip on, if there are any more, then obviously they will be reviewed. And what we continue then to do is to keep in contact with the teams, again, through the clinical areas. And obviously, we're seeing a big increase in requests from GPs via Consultant Connect to discuss particular patients around progression of their disease processes and how they can mitigate that from the GP surgery rather than sending the patients in as an emergency.
Thank you.
Okay, Simon, your hand is still up. Rachel,
I did want to say something. Rachel, just come back on your cancer point. I think the board needs to be strategically interested in cancer. I met with Hemant, who's one of Matt's deputies, recently to listen to his clinical strategy for cancer. In fact, I think what he's got to say is incredibly important. And I'd like board members to give consideration to inviting him to come along and present a cancer strategy for the organisation, because when we look at these reports, we look through the lens of immediate patient actions and how we are doing on 62 or 100 day. And that is important, but it doesn't tell us where we want to be over the next year. And I think the board would benefit from hearing from our lead clinician on cancer and getting behind some of the ideas that he's got about how he wants to take the organisation forward so it can really fulfil its mission about being a great place to come to be treated for cancer. So I hope people would support that in a future public board, we should be having that debate with our lead cancer clinician.
I'm sure they do. Tom, we'll go to Tom and then I'll wrap it up at the after that with a bit of luck. Tom.
I presume to reinforce Simon's point, at QGC last week, I mean, clearly we keep a very close eye on what the trust are doing with respect to cancer, and Hemant came and updated us on progress. Carl's touched on a number of aspects of that progress, and I think it is an excellent presentation, as you say, Simon, which not only addresses what we need to be doing and our plans to address it, but also looks forward about how we can be improving our service in the future. And we will continue to do that at QGC. I would have no objections, subject to the chair's view, about that also being offered as part of the public board as well.
Okay, that's everybody, I think. I think we, as an organisation, it's been a long time where the indicators on our cancer performance have been red, and that was exacerbated by phase 1 of COVID. And it is good that all those numbers are improving, but this is if not a long-term, a medium-term strategic problem in that how we've got to think about what we're going to do, both within NGH but also within the group. So I'm obviously happy for him to come along, and I think these things should be put in the public domain. But I think what I would ask you guys is that we arrange for the 3 leads. There's only 2 in post, I appreciate that. But when the 3rd one comes in post, in our new joint clinical leads in ENT, breast, and in due course cardiology, and Hemant for cancer, to arrange a running order for these guys to come along and talk to the board about what they're doing, and what their plans are, what they've been successful in, and what difficulties they're facing. Because we're committed as a board to taking advantage of the group, and thinking, particularly in the case of, for instance, the ENT head and neck service, particularly around head and neck cancers. It's a complicated issue. So we are absolutely committed to making those 3 joint services successful, and also to improving our cancer performance so that we become steady green, for want of a better description. I think it was Rachel that said it's a scary and lonely place, so it would be nice that people weren't in it for very long or any longer than they have to be. I'm grateful to Sharon for saying that the clinical nurse specialists are now fully active in those relationships. That wasn't always the case, and clearly they're expert in that. So I think that's a good progress, and I'm sure we're all grateful to Matt for working to oversee the whole cancer development. But this needs more work, and it needs more clarity on the plans, and it needs to look up at the horizon rather more than down at this week's work. So thank you all for that. That was excellent. Tom, your hand's still up. I guess that's an old hand.
No, I was just going to reinforce what you said. Sorry, Alan, but just to highlight that, as you know, the quality governance committees at both organisations are taking the benefits of the opportunities offered by the group model, and are now going to have, hopefully, subject to approval, alternate monthly meetings. And one of the regular items on the agenda will be exactly what you said, services where the group is working together for the residents of Northamptonshire broadly, and we will be looking at those free services in the way that you suggested, and potentially offering services up on the basis of performance, safety and quality to the collaborative committee to consider future appointments.
Okay, thank you very much. Excellent. Back to you, Debbie, and presumably over to Phil in one smooth move.
Yes, correct. Thank you. Phil?
Okay, thank you. I'll start by thanking Simon for his kind words at the start, and just to say I know Bola is more than capable of stepping into my shoes, and I know she'll have all your support. So month 7, we're now into the 3rd change in how we're managing our finances this financial year. So right at the start of the year, we had we were planning against the long-term plan. Then we had the break-even scenario for months 1 to 6, and we're now into a different scenario for months 7 to 12. In October, as part of a joint system plan, we submitted a 7 million deficit plan for month 7 to month 12. The bulk of that deficit related to two things. One was something called other income. So income like we were getting from restaurants and car parking and so on, which we're not going to recover. And also the increased costs of the elective work, particularly the premium costs around insourcing and weekend waiting list initiatives. That was our response to the reset activity plan on R=1 that was submitted in September and discussed at our September board. The plans for Northampton system haven't been formally signed off, but we know that we're not one of the systems that has been brought in for further discussion with the region and the national team. So for October, we had a projected deficit of £500,000. We came in at £300,000 deficit. So a positive 200,000 against that particular position. The next bit I'm going to talk about really is capital. In the last month, we have formally received the memorandum of understanding and cash around both the ITU and emergency electrical works, which is over £23 million, which is really good to get, official confirmation of those in writing. And the biggest risk to our finances this year relate to the ITU. And some delays that we've had in building some issues around what we found when we've dug some boreholes. Despite 40 boreholes being put in place beforehand, we found some asbestos buried in the ground, which has led to delays. And what that potentially means is there could be some slippage on the ITU scheme into next year. And at the moment, we do not have acknowledgement of being able to slip capital between financial years. Discussions have started. I've raised it face to face with the regional team, and it has been in writing as well. And I think that's one of the biggest issues that we'll need to continue discussing with the regional team to try and find a resolution. And Bowler and the capital team are fully aware of that, as is Stuart, who lives and breathes this with me on a daily basis. So really, just to say, we're into a new regime. We're slightly ahead on that, but as more and more COVID comes in and interrupts our elective and so on, from a financial position, I'll use the term might help the finances, because the insourcing and the waiting list initiatives are quite expensive. And we'll just have to see how the remaining months of the year go as COVID peaks and as the vaccine comes in and so on. So it's still a bit unknown for all of us. So I'll stop there and pass to David. Debbie, is that okay?
Yeah, lovely. Thank you. David, anything you want to add from the committee of the board, please?
No, I think at this period in time, finances are the least of our concerns, but it is very interesting what Phil was just saying about some of the perverse consequences of the present financial arrangements, that they can almost benefit us if we indeed call it benefit. Just let me add, I do think that the move away from the pre-COVID systemic deficits which the trust was experiencing is a good thing. What it does mean as we move out of the second wave, as we move out of winter, as we get into better times, hopefully, is that this is rather like a block payment, and the focus will more and more be on expenses, since we have less and less control on the income side of the equation. So and in that context, it is interesting to note that we're running the hospital at the moment for the same price as we were running it last year, but at 65% of the activity. So that's something we really have to watch out for as we move forward. That's all I have to say, I think, Debbie.
Thank you. Do we want any questions now on finance? I don't think anybody has got their hands up. So we will move on to workforce then. Mark, please.
Thank you, Debbie. So I think it's the first time we've ever sat in the board and heard that finance is the least of our concerns. So that's something new for me. So thank you. I just wanted to give a brief update. I'm not going to go into all of the detail around the metrics that you can see on the report. We'll note, or board members will have noted, that March and April's figures dropped out because we weren't reporting because of COVID, but we are going to look at retrospectively putting those back in just to give that position. In terms of some highlights following the People Committee, as I say, of Monday, we noted there the reduction in our vacancy rate, which has been heavily supported by our international nurse recruitment campaigns that we as a board signed up to last year, and that is most definitely showing its benefits now this year, as you can see, with the vacancy rate position against our substantive staff. I think I just say that based on all of the additional wards that we have that are not open, etc. But based on our substantive staff, we've got a fantastic position, and to have an acute trust below 4% for registered nurses and midwives as a vacancy position is pretty incredible. And we're not stopping there. We're not stopping there at all. But building on the work that we undertook with international nurses last year, we're now coming together as a system to work across the whole county to continue to build that work. And we've been supported by national colleagues with a number of funding bids to help assist us with that work. I think it's fair to say that we're doing a sterling job in bringing colleagues from overseas to come and work with us in the county. It's then about how do we continue to develop them once they're with us and how they can progress their careers within the NHS and hopefully clearly within Northamptonshire. So that's fantastic. And as I say, we've now got a strategy being pulled together for a longer term work stream around that. Absence has increased. Debbie mentioned this in the report earlier, and as we've also mentioned on a number of occasions, health and wellbeing of our staff is really important to us. But we have, in line with the country, as you would expect, seen more absence, particularly of that from a COVID-related absence. We haven't had too much of a dramatic effect in non-COVID absence, given the time of year that we're in. We're seeing those natural trends being formed, but we have had an increase in COVID-related absence, and also in terms of absence from colleagues in relation to self-isolation with friends and family members and so on and so forth. So, but we are managing that, as Sharon has articulated, in terms of daily staffing, sales and huddles too. From a training and appraisal perspective, again, given the situation that we've been working within for the last 9 to 10 months, those figures have dropped. You can see that in the report. We are working with colleagues to see how we can best undertake that training and maintain that competence in the most time efficient way to ensure that we keep our organisation safe. And we're also developing a new appraisal light process, so acknowledging that we may not be able to have the long and detailed conversation that we would wish to have this year, very much looking at current objectives and what we can do in the next year and making that process as seamless as possible, whilst really importantly checking in on colleagues to see how we are. I think Priya articulated that fantastically well in her vlog earlier. It's really important that we continue to look after each other and ask ourselves that question. So we know whether we do that for an appraisal process or not, it's important to continue. As I say, I will not go into any more detail on health and wellbeing, and I'll send that round. At the group briefing session just 2 weeks ago, we gave a really thorough update on that, and that's a lot of excellent work, including all the FAQ, frequently asked questions updates, following national guidance we received moving into lockdown too. One thing that I haven't talked about here or didn't put in the report is in relation to the staff survey. So it is still that time of year where we're asking colleagues to complete the staff survey across the organisation. Last year, as a board, we'll remember that we achieved 40% completion rate. I'm pleased to report that as we sit here right now this morning, we're at 48% against the set target this year of 50. So we have until tomorrow at 5 PM. So if there are any colleagues on the call that have not yet filled in their survey, please do, but because it's really important and we'll give that a real good push. I think that's really, really important. That will be over 2,500 people that would have given us their comments and feedback as to what it is like to work within the NHS, and as importantly, or more importantly, what it's like to work within NGH. And then we can build on that progress over the next few years. Whilst we continue to develop the people plan, we held at the People Committee this week the progress around that, and we are very much still on track for the end of January to bring that people plan to this board for approval and then to get mobilising. That was all I was going to say, and David had he chaired the People Committee this week as well, so it could be over to you, David.
Yeah, sorry. Yeah, I was doing a lot of chairing this week. No, I think Mark has covered everything. There were two committees. Let me just explain. There was the Shadow Joint Group People Committee, which met, and directly after that, the NGH People Committee met. And I'd just like to reiterate the fact that both the committees expressed their deep appreciation for the work being done around the flu vaccination program, COVID testing, now the lateral throw testing, which 8,000 frontline workers in the group have to involve themselves in, and now the planning for the rollout of the COVID vaccination. And this is all on top of business as usual, and this is a tremendous effort by everyone involved in this work. Worth also noting, I think, and a lot of time was spent in the committees on this, was the great work around the health and wellbeing program, which Mark has just mentioned, and this is having a very positive impact. And staff will continue to come under significant pressure, so it's great that we've got this good program in place to support everyone. Finally, just the vacancy rates. Yeah, this is really good news. I mean, any organisation anywhere in any industry would really be proud of a vacancy rate which is less than 4%. And we've managed to do this in nursing, so it really says a lot about the success of our international recruitment campaign. So that's it, I think. Debbie?
Thanks, David. That's really good. And you're right, the vacancy factor is really good, and a credit to everybody that's been working on recruitment. Okay, I think we've got some questions. Rachel first.
Yeah, just a quick question for Mark on the vacancy rates, which I think are excellent. Do we know why they're so good? Because part of the way, I assume, of keeping them low is to know what's driving those low figures. And also, how do we compare with other hospitals in the country?
So in terms of the nursing specific vacancy rate, we absolutely know the driver, which is in relation to our international nurse recruitment campaign that Sharon and the team led last year, and we had to delay because of the COVID situation and bringing people across. So that is the driver. The reason why it continues to, or why it is so low and continues that way, is also because turnover is low. So we're not losing people. People aren't choosing to leave us as an organisation at this current time too, which is also great. So they are the biggest impacts as it stands at the moment in terms of the vacancy rate position. In terms of how we compare, and it's strange, isn't it? Because in a public board, you want to celebrate the good low vacancy rate, but equally you don't want to alert people to the fact that you've got lots of very good qualified nurses working for you, if they've come over with some sort of recruitment or advertising campaign. But we compare very well, very favourably in relation to a nurse vacancy recruitment rate. It's now our ambition, obviously, to get into a similar position with medical staffing and other healthcare support workers, etc. So it's a real testament to the international nurse recruitment campaign, and we know some of the work that is happening in our higher educational organisations that, again, Sharon and I are linked into, will help us also in the future in terms of national qualifications and people who are able to come into the profession. But we believe the international nurse programme will need to be around for a good couple of years yet. And that is borne out in the National People Plan, where the ambition is to bring, I think it's 40 to 50,000 colleagues into the NHS.
If we took those overseas employees out, do we track well on the turnover statistics without them?
From turnover, yes, our turnover historically has been good here in NGH. Our turnover, we don't have, thankfully, a number of colleagues wishing to leave us and moving on. So even if we were to take out the international nurse recruitment that we've undertaken, our turnover remains good.
Thank you.
Thank you. So I think Jill has a question.
Thank you. I just wanted to pick up on the training you were talking about, Mark. In the QGC meeting we had last week, we were looking at levels of training in relation to PPE. And Sharon was explaining how long it took for the figures to get inputted into the computer and come out the other end, so to speak, so that we got proper validated data. So I wondered if perhaps the data that you're sharing with us is not real time. I mean, it may be, but particularly with PPE, is there any other way that we can speed up the process? Because the IPC team have had to do spot checks on wards to make sure that they are all trained, and that doesn't align with the figures. So I know some trusts are using smartphones and apps so that they can input the training numbers, you know, as I say, in real time, which then gives us really good validated data. So a kind of broad question around training levels and are we capturing them appropriately?
Yeah, so it's absolutely, thank you, Jill, for the question. It's absolutely something that we need to look into in terms of technology being a solution to our issue in terms of real-time reporting. We don't have real-time reporting at the moment. E-learning helps support that, because when you complete the module, it'll automatically update into your ESR record. And we don't have that at the moment. So the data that we're looking at, to answer your question, is back in October data. So it's not real-time November data that you can see within the report. And I am trying to support the team in doing that, but I am mindful, as has been alluded to in terms of the flexibility of my team at the moment, that team are also doing quite a lot of work in relation to COVID testing and bookings and so on and so forth. So we are absolutely looking at it as a future solution. I suppose I'm not putting too much pressure upon them at the minute, given all of the other activities that they're undertaking. But if we had an app and a digital solution, of course, it takes out that human interaction and we can do it much quicker.
Thank you. Denise?
Yes, thanks, Debbie. Mark, it was just, I think we said that we were also going to just mention the approval that we gave to the advanced care practitioners at the Joint People Committee, because I think that's a really exciting thing to look forward to.
Yes, thank you, Denise. Yeah, there was too many to mention, but one of them was the advanced care practitioners. So we had a presentation by Vicky O'Neill, who's our medical education lead, who came along to talk to us around advanced care practitioners and a development program set around those. And by benefit of the fact that we had a joint committee, we had colleagues from KGH there too, that were able to sign up and approve this as part of a group model in terms of moving forward with this training program for these colleagues, because we know, again, in the future, the number of training, or the training numbers we have for medical colleagues are not where we may need them to be. So the advanced care practitioners will absolutely be able to undertake some of this care. And we agreed that, as Denise said, across the group.
Thanks, Mark.
And I think we've got Sharon, and we can probably go straight into your update also, Sharon, please.
Thank you very much, Debbie. So I just wanted to come back, Rachel, to the question that you asked. Why is our vacancy rate and turnover rate as it is? I firmly believe that as a pathway to excellence accredited organisation, that gives us a really special culture that makes our nurses and midwives want to stay in the organisation. And it also is an attractive pull for international nurses to want to come and work within the pathway organisation. But I'll talk about that a bit later. Okay, so moving on then to my part of the performance review. There are two things I particularly would like to highlight to the board. Firstly, in relation to complaints, the complaints process was stalled during the peak one of the pandemic, and our staff were redeployed in the organisation supporting patient experience. We have now reinstigated the complaints process, and that's formally nationally, and I'm really pleased to share with the board that actually all complaints registered in August were responded to, so 100% response within the agreed timeframes. And I think that's an absolutely fantastic achievement, not only by the complaints team, but by those people that had to investigate and respond to the concerns that had been raised. And the second thing I just wanted to raise with the board is in relation to our COVID response. Our infection prevention team, as you can imagine, are working phenomenally hard, supporting, training, educating patients, staff members on how to stay safe during the pandemic. When I wrote the paper, we had seven COVID-19 outbreaks. The definition of an outbreak, for those that aren't familiar, is 2 members of staff or 2 patients working or living within an area is constituted as an outbreak. We now have 12 outbreaks on site, and a number of those have been caused by patients or staff being absolutely asymptomatic and only picked up on routine testing. However, we have daily outbreak meetings, and to put some assurance in, which is attended by the CCG, PHE and NHSCI, and we have been complimented on the way that we have been managing and will continue to manage outbreaks. As I said earlier, the IPC BAF had been discussed at the Quality Governance Committee. We were able to note the progress that had been made, and we're paying particular attention to our PPE training and to the increased provision of our domestic support team, which I know Stuart and his team are working really hard to ensure that we can meet the increased numbers that are there. That really summarises what I wanted to say. Tom, did you want to add anything?
Thanks, Sharon. Just to reinforce those comments about the IPC BAF, as you know, we had a detailed discussion at QGC. I think, yes, highlight the cleaning and the progress on that, but the continued need to progress on that, highlighting the PPE, and I think it's really important for the board to note that where the PPE policy is not being adhered to, that's called out, and however senior the clinician is, it is challenged and called out. So there is, day to day, hour to hour, minute to minute, very close attention paid to the importance of PPE within the organisation, and to making sure we deliver on the agreed plans with the CQC around managing COVID.
Thanks, Tom. I'm going to go over to Matt now for his update, please.
Thank you, Debbie. I shall be succinct and take the report as read, choosing to highlight just 2 items, if I may. So pleased to be able to inform the board that we have begun our rollout of e-rostering of medical staff, which will help the Trust make most effective use of their expertise and resource, and also improve the experience, in particular of the junior doctors managing their work-life balance. I'd also like to I'm pleased to be able to confirm to the board that together with Andy as our new Chief Digital Information Officer, that we've got an agreed way forward for the reintroduction of electronic prescribing early in the new year, which will, of course, substantially improve medicine safety alongside the rollout of our ward-based pharmacy project, and also deliver the step change in VTE assessment and prophylaxis that we are looking for. Again, would invite Tom to add any comments on the medical elements of the QGC meeting.
Thanks, Matt. Really nothing more to add. There was just a couple of items. One was just around maternity, Chair, if I may. That was a particular focus of QGC last week. And in particular noting the progress that has been made in a number of areas, and also particularly in respect of the maternity incentive scheme, that there is work to do, but we have a plan to deliver that by the required period next year. And the second item that we did, the other item we highlighted, Chair, just to bring to the board's attention, and I'm not necessarily sure this applies directly to what Sharon or Matt have said, but there's not necessarily another opportunity for me to talk, but we were asked to bring this to the board's attention. We've had an HSE visit. As you know, there was a concern earlier than this year, which resulted in an enforcement notice around production of radiopharmaceuticals. HSE were very satisfied with the progress that we were making. It was a positive visit, and there were no enforcement notices or any particular need to follow up in writing with any of the actions that the HSE undertook at the visit. I think that I have notified that correctly, Claire, but please come in if I've misinterpreted anything that the QGC asked me to bring to the board's attention.
No, you absolutely have. Thank you, Tom.
Thank you both. Jill, you've got your hand up.
Thank you. I just wanted to add to what Tom's already said about the maternity incentive scheme. There's an initiative called 10 Steps to Safety, and if the Trust achieves these 10 standards, there is a 10% reduction on our premium, which we pay to NHS Resolution for litigation. This is a very tough thing to achieve. In fact, we were the only Trust to achieve it in the region last year, I believe. And and it's even more tough this year. Now, Sharon and I have heard on the grapevine that actually the timescale might be delayed because every trust is struggling with this. And although we have an action plan in place, there's still quite a lot of red areas on it. So what I can assure the board is that those areas are not in relation directly to patient safety. They're things like we haven't got the appropriate IT platform to send our data into the national team, for example. So that's one of the standards that we're struggling with. So just to say to the board that there may be a risk to our premium, which is 10%, which is quite a lot of money. But as Tom says, there is a plan in place and colleagues are working really hard on it.
Thanks for that update, Jill, really important. I'm conscious of time, but we do have Rachel with us, and I would like to just hand over to Rachel to give us an update on the collaboration committee, please.
Thanks, Debbie. So the update is that in November, we focused on the clinical collaboration progress, which is going well. That's breast, neck and head and oncology. There is some more to do there because obviously they are impacted by the second wave of COVID. We also discussed at length the importance of patient engagement in planning those activities. We then briefly touched on the vision, mission and values, but they are coming back to CPC in December. So we get a breather from those for a while. And then in terms of the committees, we went through how each one was progressing towards a group collaboration model, and they're going at different paces. The people committee is making really good progress. They are quite well established in how they are moving forward. The others less so, but they are all at the stage of at least terms of reference are agreed, and we're looking forward to seeing those progress over time. Thank you, Debbie.
Thank you. No further questions I can see from anyone. So, I think we've talked through a huge amount, but you can see the amount of activity that's going on in the organisation. So thank you, Chair.
Okay, thanks, guys. Reset and recovery phase 3, which to some extent we have just touched upon during the earlier one. So if you could be quite crisp with this, Carol, that would work well on the timing front.
Absolutely, Alan. As you say, we've covered a lot of ground. So this report lays the NGH activity for October against the phase 3 reset model that we submitted to NHSCI on the 21st of September, so not that long ago. Model was based on activity from September to March 2019 to 2020, and those assumptions reflected COVID at being R equals 1, stranded and super stranded being at September's level, and obviously took into consideration any insourcing or transformation work that was in place. Clearly, we're in a very difficult place now. The October position identifies that overall the referrals to the trust are slightly below the figure expected at 85%. So we've got less referrals coming into the trust, and we've also had less patients on our waiting lists. However, we do have an overperformance of other referrals of 21%. And those other referrals include internal referrals in the hospital, community and nurse-led clinics. The number of our outpatient attendances is below plan level slightly at 93%, but it's pleasing to see the massive overperformance in virtual outpatients, i.e. non-face-to-face appointments, which are almost 3 times what was predicted. And it's also important to feed back that we've had really, really positive feedback from patients following audits of the virtual service, and they really want this service to stay in place. Day case and inpatient activity is below modelled at levels at 88%, and this is attributable really to the maximum theatre capacity not being available until mid-September, and some of our insourcing support not starting until early November. This coupled with a loss of theatres and to ITU pods and endoscopy has challenged our position, but COVID permitting, we will increase and be sustained going forward. Both ED and non-elective activities below the model levels, but that's not surprising, with a notable increase in the COVID admissions that we have seen obviously continue significantly into November. I've covered the diagnostic and cancer activity, but to note that we expect endoscopy units at Daventry to open in the new year, and that will further support our position. Overall, given the phase 3 submission that was modelled as R equals 1, and as county, we've been hovering around R equals 1.2 to 1.5. I'm pleased with the overall performance and the massive amount of work that teams have put in very challenging circumstances. I'm happy to take any questions.
Jill, I think you have a...
Sorry, it's my fault. I was muted. Thanks, Debbie. David?
Yeah, it's more of a comment than a question. It really is good news to see that, you know, consultant-led first outpatients attendances by telephone and video are, you know, are really up there and are really far more than we expected when we went through this planning exercise. And, you know, long may that continue, because it has significant impact for how we work in the future, and no less so in the design of our estate, for example. You know, how are we going to change what we're doing, how we're designing our estate, and all of this good stuff as we move forward. So just a comment that good to see this, and let's hope the traction continues.
Yeah, I agree with that. Anecdotally, it's very popular with patients. I don't know if we have any factual stuff on that as opposed to anecdote.
Alan, yes, we do. As part of the software, patients can leave comments after their consultation. We've also done some face-to-face as well, and both methods feedback very, very positively indeed. Okay, jolly good. Okay, that's fine. Thanks. Winter plan, a bit later in the year for the winter plan coming, but I understand the problem. Carl, keep going. Yeah, okay. I will be very brief around this one, and I don't propose to take everyone through every single slide. Other than to say, I have led the winter preparations for the last 4 years since I arrived at NGH. And I think it's fair to say this year's plan is very different for a very different winter. As such, I've abandoned my usual format to include actions that are very different from the norm. To be honest, I never expected to be writing a winter report that focused on staff well-being, both physical and mental, and the support for our exhausted workforce as we get ourselves through the next few months. Nor did I really expect to be having to include Brexit in our winter plans. As I say, given the time, I don't propose to go through the slides. You'll see 3 of the slides are focused on our well-being of our staff as we go into winter. There is a slide around Brexit and detailed information around how we bridge the gap with the bed numbers, given that COVID is not at R equals 1 and is at a significantly higher rate at the moment. Very happy to take any questions around the winter plan.
Yeah, I can't see hands on this occasion because of the way the screen's overlapping for me. Has anybody got anything on this at all to speak? No, I think it is an entirely different winter plan. You're absolutely right, Carl. And of course, there's a lot more unpredictability in these things. Normally we're debating a few percentage point shifts in demand at this point. And now we're talking sort of another 90 beds occupied by somebody or other, or not, as the case may be in COVID. So this one takes us into a level of uncertainty. But nevertheless, the plan is in place. It's learned from previous ones, and the data sitting behind it is probably more thorough than anything we've done before. So good stuff. Debbie.
Yeah, thanks, Chair. So it was an apology, really, just to say it's obviously late this year for obvious reasons, but I'm really pleased with the plan. It's a thorough plan. It also includes system working within there. And I know that the Chief Operating Officers have been doing a lot of work with the system, with system partners. So it is truly joined up, not just across the group, but across the system. So thank you.
Okay, good. Anybody else? No. I've not got anything else. Okay, thanks for that, guys. Governance, Claire, you're going to talk, just get us through these terms of reference for joint committees? I think these have all been through the committees and all been agreed, but can you just bring them up one at a time for approval?
Certainly, thank you, Chairman. Just to outline to the board, you'll all be aware of the reasons for having these joint committees to support the collaborative working in the group model and to make sure we have got robust and sound governance using the committee in common processes. So today we have two joint terms of reference for board approval. These have already been through the Collaboration Programme Committee, who have agreed them, noting that these will be iterative because this is the first iteration of them, if you will, and I'm sure as we develop we will need to take another look at them. So the first ones we have for the board's approval is the clinical quality, safety and performance, which Tom kindly did a really nice preamble to earlier for everybody. So these are here for the board to ratify, really. So that's the first thing I'm asking for today. Any questions on those? No?
Jill, your hand is up.
Yes, it's a really minor point, Claire. On page 92, under frequency of meetings, it says bi-monthly and scheduled to occur on the same day as KGH and NGH quality committees. And I don't think we intended all to meet on the same day, did we?
No, actually that should be finished. The sentence should finish at bi-monthly. So I will amend that.
Thank you.
Okay.
Impressive, Jill. Right.
So if everybody's happy with those, I'll take those as approved. The second terms of reference are for the Digital Hospital Committee. NGH did not have a board committee of this nature prior to this coming forward. And currently there has been a setup at KGH where they have had this. So the proposal is for these this to be chaired by the chair of the current digital committee at KGH to ensure continuity, obviously with support from non-execs here. This is something we are able to delegate under our standing orders as a non-FT to our FT collaborative organisation. So I'm asking for approval of these, as well as approval of delegation of the chair to the KGH chair. And the other thing I just wanted to add was huge thanks to Andy Callow for turning these around in super quick time and getting these through to CPC this month, which was no mean feat. Any comments or questions?
Okay, thanks, Claire, and I'm taking that as approval to a delegation. From my point of view, I think, I mean, this was a relatively easy decision in regard to the Digital Hospital Committee, because the chair there, Alice Cooper, has had experience of significant change and really rapid implementation of systems, and it's done a very good job in KGH. So I think the continuity and so on was an easier question here. I am very conscious of the demands on non-exec directors and what we ask of them to do in their contracts and so on. So I think as we move forward, we're going to have to think about the lessons learned from these joint, we are going to have to think about the lessons learned from these committees. I think we have to think about how they're serviced. We can't alternate the servicing between staff in two hospitals. We need to think about how they're supported, and we need to think about how we get some consistency into the chairing. And that's not necessarily means that one person has to be the chair, but we may have a consistent period of time over which one person chairs it. Experience of chairing moving around, which was the healthcare partnership experience, was that effectively nobody chaired it because the continuity was lost of what a chair brings to these committees. So I'm not suggesting a solution today. I'm just making the point that as we go forward in these joint committees, I'd hope chairs would think about how we can do this in the best way, and I'd expect Claire and her opposite number in Kettering to be thinking about how to make the support for the committees absolutely consistent, so they are genuinely joint committees, not committees that bounce between two hospitals or two bits of leadership. And I know they're aware of that question.
Could I just respond to that last comment, Alan, in that Richard and I had that very discussion yesterday regarding support to the committees, and we have a plan to start rolling that out. We need to obviously discuss that with our relevant support staff who will be doing this, because this will be a change in their work patterns too.
Yeah, obviously, and we're grateful for everybody being flexible about that. Okay, thank you. That's that item finished, isn't it, Claire?
Yes, thank you.
So you're now on to terms of reference for the audit committee, which
I am, and I don't intend to dwell on this. These have been through the audit committee. It's their annual review, and they are coming to the board as the parent committee for approval of the minor changes that have been made, unless John wants to add anything.
No, I'm entirely happy, thank you.
So,
I'd like the minutes to record that Mr. Archer-Jones is entirely happy, and then we can move on.
thank you very much.
Okay.
So the board assurance framework, this is the Q2 report. This has been through all the committees. The key thing to draw the board's attention to here was a discussion on target dates for achieving the scores that we have on there. And it has been agreed that that will be in line with the next full review of the BAF, i.e. in the next financial year. So as a result, the target scores have been amended now for risks 1.1, 1.8, with the people committee needing to do some further work on the risks within there. Risk 1.6 on page 112 has now reduced the score. This goes back to the discussion on our recruitment, particularly of overseas nurses, and the score is now at the target level. And risk 1.10, which is the recovery plan post-COVID, that score had decreased from 20 to 15 because of the mitigation put into place at that time. Overall, the risk score has decreased in this quarter from 236 for 16 risks to 226. Happy to take any questions.
Okay, we're always we're confident in the process that sits behind this risk assessment stuff, but nevertheless, we need to make sure the board is absolutely clear on the oversight. So, Simon and then Jill.
Thanks, Claire. So we're at the point in the year where planning guidance is going to be released, so we can start to take a bead on what the likely challenges are for the NHS in the year ahead. At the moment, the kind of draft planning guidance is going to be released in December, and I think it would probably be apposite for all committees of the board to revisit their risks, to consider whether either some of our risks need to be amended, some new ones need to be added, and indeed some need to be removed. So let me give you an example of that. It's likely that next year will be a hugely important year for the NHS in terms of elective recovery. And a critical success measure for organisations will be, and also for systems will be, how they engage in that work and what they deliver during the course of the year. So as ever, when we have a BAF, it reflects a present moment or slightly past moment in time, depending on when we capture the data. And I think it would be incumbent upon us to take a slightly more forward-facing look as the planning guidance comes out, and bring the BAF back with not just the very well articulated current set of positions, but also risks that the board might need to be thinking about before we get anywhere near next year. Because normally we don't, I think we need to take, I guess what I'm saying in simple terms is, let's take a more strategic look at our risk horizon.
Okay, and the guardian of risk, John Archer-Jones, is nodding at that as well. So I think we can be pretty confident that's got approval. Jill.
Thank you. It was a small question, but I think quite an important one. On page 125, we've got a statement that says that there's an intention to reinstate board to ward visits virtually. And I know the non-executive directors have really missed not doing the board to ward visits, because it helps us triangulate evidence that we receive in committees and in papers. So I wonder how we were going to manage that. I'm actually doing a drop-in session with staff virtually this afternoon, with midwives the maternity unit, not just midwives, and the neonatal unit. So it'll be interesting to see how that goes. But I just wondered how that was going to be managed, and when does it start?
I'm going to hand over to Sharon to answer that question, because that's out with my detailed knowledge.
Thank you, Claire. It's a really good question. You know that we've talked about that previously, and you and I have done our drop-in visits to the emergency department. I'd really very much like to see how the drop-in visit works this afternoon with maternity. I know this is the second that you will have done with the team. I think given the pressures on the organisation and our staff at the current time, that indeed the model that we're testing today might be one that we could consider for other areas. So staff could then connect with our executive colleagues if they wish to, rather than us possibly taking up their time when they need to be, or they want to be caring for patients. Would that be agreeable?
Thank you. It's a really fine line, isn't it? Because you're absolutely right. Our staff, we've spoken endlessly about how busy they are, how tirelessly they're working, and the last thing we want to do is get in their way. So yes, we could evaluate how the drop-in sessions are going and see if it's a model we want to pursue over the next few months, and hopefully by spring next year we'll be back to being able to do the actual face-to-face visits.
Absolutely.
I know you're all missing the visit stuff, and I've had a conversation with a few people in nursing in the last little while, and hopefully we can start to think about reinstating those probably from April, depending on the vaccination program, and I guess, like always, there'll be some guidance somewhere about it. Okay, thank you very much, everybody. That's really good. Stuart, fire plan, and I just make the point as you start that we will go to the academic strategy at 11:25, even if we're not quite finished, because we've got an external speaker at that point, but we'll come back to finish anything we need on the fire plan. So over to you.
Okay, thanks, Chair. I'll try to be as succinct as possible. So this is the operational plan for 2020 to 25. Outlines our key fire strategy or fire safety priorities for the management of fire safety. We've discussed fire at the board regularly in private and public, so this is presented as a further level of assurance. The plan sets out how we're going to manage and how we'll invest and upgrade our fire management systems over the next 5 years. It's a live process. The plan has to be flexible, so we'll continue to monitor it, because we know from experience that whilst the priorities of this plan will remain the same, opportunities throughout the year, whether that be access to areas or whether that be new developments, will mean the plan will be able to flex, and we take those opportunities as they arise. The plan will be managed through the estate's fire technical group, which is monitored and approved through the Fire Safety Committee. And then the actions of fire safety is also included in the estate's compliance report to finance and performance. I'd also like to take the opportunity to update the board from our last discussion on fire safety. So we've produced this plan, but also all the fireworks now on the critical care floor have been completed. So we handed back Dryden Ward yesterday, which completes all the compartmentation work, which we've discussed at length. All our fire risk assessments are in date and in place. Our fire drills, plans, wardens and training are all in place across the site. And in the last couple of weeks, or last week, we received the fire safety audit results back from TIAA, internal audit, which gave us a rating of reasonable assurance, which is good. And the move to substantial assurance, one of the main recommendations was actually having this plan in place. So we're well underway to do that. And then finally, although it's going to be covered under a separate paper and we'll be discussing later on, we had an activation, fire alarm activation in ITU on the 8th of November, early hours of Sunday morning, as it would be. Not something that we would have wanted, but actually it's a perfect example of why we have the plans and drills and the progress we've made on fire safety, because the whole ward was evacuated in under 10 minutes. And I would like to minute as well, just my thanks to all those staff involved in that evacuation and to the fire service who came in and were more than happy with what we achieved and how it went. So if I pause there and take any questions.
Anything at all on the fire plan? I mean, we've spent a lot of time on this, quite rightly so, and particularly around ITU. And I know we'll talk elsewhere about the investigation into the events around the fire alarm, but if you are going to test a system in ITU for evacuation of patients, and doing it pretty early on a Sunday morning is a pretty good way to find out if it works, and it did. So that's extremely reassuring that patients were all moved within a very short time frame into a very safe space with no problems. And we'll come back to that in another place as we begin to understand just the nature of the incident. But well done to that. It's a good comprehensive programme, Stuart, and it gets us to a much reduced risk rating reasonably quickly. It's steadily coming down. And I think it's important that we find every way possible to stick with the programme. We can't afford to allow slippage. And I take your point about access being possible through the year, kind of serendipitously. So that's all good stuff. Anybody else at all? Yes, we do. Denise and then Jill, please.
Yeah, thanks, Alan. Mine's more of an observation rather than a question, and it's around the fire safety training side of things that I know we've talked about before. So I just think, bearing in mind everything that we've been talking about today, and we were talking about our people committee, and for understandable reasons, some of the training levels are not where we want them to be, but just that as a people committee in particular, we do need to keep focus on the fire safety training side of things and just make sure that we're where we need to be on that.
Okay, thank you for that. Thank you. If you're going to come back, Jill, we'll do it at the end. Jill.
Just a very quick point, if I may, Chair, just to say a huge thank you to both yourself and Debbie, who notified the non-executive directors immediately about this fire that happened, and also that nobody had been harmed and what actions have been taken. So the communications were brilliant. So thank you very much.
Okay, thank you very much. Stuart, you got any comments on the training?
Just the training is something we've continued focus on, so there's no question of that letting up even through the current pandemic. It's at 82% now and going in the right direction. So the fire team keep a close eye on that, as well as the fire drills. And when we see it drops, we will go out to the wards. The fire team as well, they've made themselves available to carry out fire training out of hours, on night shift, weekends. We'll go to the wards to deliver it if that's what is needed.
Okay, thanks, Stuart. David and then Mark.
Yeah, just for the purpose of clarification, Stuart, my understanding is that there were 2 fire call-outs the week before last or whenever it was. There was one on the Sunday and there was one on the Wednesday. My reading of if I read the Northamptonshire Chronicle correctly. Is there any association between those 2 events?
Nope, none whatsoever. The only link between the 2 of them is both events were carried out perfectly to the plan. So Allabone and Eleanor were both evacuated in under 10 minutes. Fire service turned up and were more than happy with the response. So yeah, it was a never test on that floor. That went perfectly well.
And okay. There was no connection between the 2. They were entirely different incidents. So I give you that. And neither turned out to be serious, thankfully. Final comment, Mark.
Thank you, Alan. Just to pick up on the training, just to highlight on page 64 and in future reports in IGR, we've got the specific fire training pulled out now, so it doesn't form just part of the statutory and mandatory training as per the last board meeting. So we've got that available.
Thank you, Mark. That's extremely helpful. Oh, look, 11:25, item 16. Medical Director Matt, would you like to introduce your guest and take us through the academic strategy? Thank you very much, everybody.
With pleasure, Chair. So firstly, it is indeed my pleasure to also to welcome Professor Kevin Harris, who, in addition to being the Associate Dean of Clinical Affairs at the University of Leicester, has also been Medical Director at University Hospitals of Leicester, and so is ideally placed to share with us an understanding of the benefits of a strong academic identity and university hospital status. I'd like, of course, I will take the strategy document as read, but we'll just acknowledge the work that has gone into producing it from teams across both trusts of this group, and to note that the same paper is being presented to the public board at Kettering General Hospital also this month. The strategy document has already been through and approved by QGC, but I will take just a moment to emphasise a few of the key advantages in support of the request, that the board should formally support the recommendations within the academic strategy, with a view to Northampton and Kettering General Hospitals becoming acquiring university teaching status. Those principally would be improved access to study participation for our patients, and the known association with improved clinical outcomes that research participation brings, enhanced opportunities for staff development and learning, and thereby improved retention, and also the opportunity to build a strong brand that facilitates, amongst other things, easier clinical recruitment. The clinical teams at both hospitals have a really strong appetite to proceed with this strategy, and subject to the approval of both boards, we have an Associate Director of Research, Innovation and Education who has started working across the group within last week, and is already beginning to pull together the elements of a detailed work programme for delivery. And could I just invite, before we take any discussion, invite Kevin to say a few words.
Thank you, Matt. Yes, and thank you, Chair, for inviting me along to the board today. It's been a pleasure to be here and to remember what it was like to be in Matt's position a few years ago. The association between an HEI and an NHS has long been recognised as being a really important synergy that results in improved patient care. The synergy actually results from the things that Matt's already articulated. We know that access to research for our patients is beneficial for them, and we know that access to education for our staff is both a way of promoting staff development and retention internally, but also recruitment to the area. So the university is really very excited about this proposition, actually, and has already approved this as a direction of its travel through the university executive board, for all the reasons that are articulated within the strategy. The opportunity in particular that's offered through the group model that you're going down is also particularly exciting, because in anything to do with academia, critical mass is really very important, whether that's research critical mass or educational critical mass. And that's not to belittle, of course, the already strong associations that the university has had with the existing trusts within Northamptonshire, and it's because of those strong organised existing relationships that I think we've gone on to be able to develop this model, which hopefully you will be able to support and allow us to progress. And I think, that's really all I need to say, other than really to pay great tribute and extend the university's thanks to the tremendous hard work of people like Matt, but also a number of other people working behind the scenes who've got this to this point, really in a remarkably short period of time. And I'm happy to take any questions on behalf of the university from colleagues. I'm sure Matt would as well. Thank you.
Thank you. That's very reassuring stuff. Simon.
Thanks, Alan, and I would just like to place on record, firstly, my thanks to Kevin for joining us this morning and for his comments and support in getting us to where we are today. To echo that which has already been said about to Matt, to Karen Spellman, I think, who has been incredibly helpful in getting us to this conversation that we're having today, and I suppose to signal my support for this. we have talked about things that the group is enabled us to do. This is one of the first big things that we've got over the line. And for me, it's probably one of the most strategically important. It will dominate, hopefully, our thinking and our work over the foreseeable future, probably the next 5 to 10 years. This is not something that we're doing trivially or for a short period of time. This is, I think I've described it as a big investment in our future and what we believe we need to deliver for the people of Northamptonshire in terms of their care and our investment in their care. Consequently, I think it will be really important that we embed this strategy in the work of the organisation and in committees of the board, so it is overseen and we continue to prioritise it and our progress against the ambitions that we have set out in our discussions at this board. I think it's a really important long-term view of our future and exactly the sort of thing that we should be attending to. I'd also obviously welcome comments from other colleagues and just thank also, I should have done earlier, but Tom as our current NED for his support in helping us get to where we are today. And Tom, I'd be obviously grateful for your views and support.
Okay, well, I'm sure Tom is going to give us his views. How about now?
Yeah, I was just thanks, Simon, and thanks to Kevin. I don't think I have much to add to what Kevin has said. I think he's clearly articulated the advantages between close working with the university and the trusts. And again, I put on record, and I know my boss, the head of college and PVC, would say the same. He's particularly enjoyed working with Simon and with others, and I think that the enthusiasm from the executive directors, but I think importantly, you know, all professional groupings in terms of taking the academic endeavour forward, by which I mean not just medical staff, but nursing staff, allied health professionals, and also technical staff, because ultimately we hope it will benefit all staff groups. And I think it's a very exciting time. We're aware of that there may be sensitivities with other health education institutions, and we're cognizant of that. And I know Matt's ensure that they are up to date and involving them in the conversations, because I think it does not stop existing productive relationships.
Okay, thank you very much, Tom. I'll go to Debbie first, and then we'll go through the non-exec director hands up. Debbie.
Thank you, Chair, and good to see you, Kevin. Thank you very much for joining us. So I feel really excited about this. This is a great opportunity for not just staff and staff joining the organisation, but the benefit that it'll bring for patients as well. So it's really well supported, and I am really looking forward to the future.
Thank you, Debbie. David and then Denise.
Yeah, no, this is an absolutely tremendous initiative. It's tremendous to be tying up with a university like Leicester as well. I've had a look at your at the paper, Matt. I see the timeline, which is great. You know, it's good news. September 2021, we should be a university teaching hospital. I don't see any risks. Do you see any risks to us meeting that very aggressive deadline?
Thank you, David. So there, it would be a very confident medical director to say they see no risks. Be raising my spyglass to the wrong eye. However, I feel that all of those risks can be effectively mitigated through the commitment and the investment that we are making. So I have a high level of confidence that during the next calendar year, together with our academic partners and principally and as a lead partner, the university status, the University of Leicester, that we will be able to achieve during the next calendar year university status.
Okay, let's move through the non-execs. Thank you, David. Denise.
Thanks, Alan. Just to really mirror what everyone else has said, I think this is a fantastic initiative. I think when you take this with the Talent Academy, Pathway to Excellence, the advanced care practitioners, all of these things strategically sit together to put us in a really great position from a people and patient point of view.
Thank you, Denise. Jill?
Thank you, Chair. I think just to reiterate that and the importance, I think, to we've had a discussion this morning about recruitment and retention rates, and this again will really add to our kudos, for want of a better word, and will attract staff, and when we've attracted them, they will be retained. So I think, as Denise has alluded to, this paper and the next paper are really important in terms of making sure that we not only attract staff, but they're really high caliber, and then we keep them, and fantastic for patients. So absolutely support this.
Thank you. Sharon?
I feel I have to put on record my thanks on behalf of the nurses, midwives and AHPs in the organisation for how they have become part of the development of the strategy and how excited they are looking forward. You know, research is something that we really want to escalate within the organisation, and so we're absolutely fully behind it and really energised by.
Okay, thank you. You did have your hand up, Professor Harris, but it's gone down again. Have you got anything you'd like to?
Well, it was just to add a response to the risks that Matt addressed. We haven't included in this a risk register, but to reassure the board, there is an operational group that sits underneath this, which is looking at risks. And you know, we would be naive to believe that, given what we've seen in the past year, there aren't risks to this moving forward. But as Matt said, we believe they can be mitigated.
Okay, thank you very much. I don't see any more hands. I just add my comments to this one. Look, I am absolutely delighted about this. When I was a long time ago in my life, when I was chief executive of Cambridgeshire Health Authority, after that Trent SHA, I put a lot of effort into building the links between the university, in one case Cambridge, and the other Nottingham and Derby. And the visible improvement in services and quality that comes from strong engagement with academic institutions and real development of clinical academic leadership is just remarkable. And in solving really difficult recruitment problems and providing a different kind of leadership, it is something to behold when it works well. So I am absolutely delighted that we have managed to take what was a slightly soft level of enthusiasm a year ago into something which is really quite well down the track. And I take the point about risk, but I'm clear it's in everybody's interest for all sorts of reasons, some to do with the A-level system, some to do with something bigger than that it's in all our interests to get this show on the road by next September. And we're absolutely committed to doing our bit, and the benefits will be rapid and long-term. So I'm delighted about that. Thank you very much for joining us today, Evan. And I am absolutely clear that there's a unanimous board approval and enthusiasm for what we're going to do here. And I've got a lot of people nodding their heads. So thank you very much, everybody. That's an excellent outcome from I know some really hard but enjoyable work that people have been pursuing over the last few months. So thank you very much, everybody. Moving on to Pathway to Excellence. For those of you that haven't noticed, Northamptonshire's in Tier 2. It was announced a little while ago by the government. So and there are certain things you can't do anymore, and there's a few things you can do. You can look forward to getting your hair cut for the most part. It's not something that bothers me. But moving on, academic study, Pathway to Excellence. Sharon.
Thank you very much, Chair. Kieran, could we have the presentation, please? Thank you. So I'm delighted to be updating the board on our current position with Pathway to Excellence. I recognise that for some board members, this will simply serve as an update on the work that we've been undertaking, but for others, this will be new. the presentation is going to serve as an introduction to what we believe has given our nurses and midwives the structure and framework to see NGH as a great place to work, where our practice environment is the best that it can be. So what is Pathway to Excellence? Next slide, please, Kieran. It's simply an international nursing accreditation system led by the American Nursing Credentialing Center. There are 196 Pathway accredited organisations across the world, and we were the first trust in the UK to gain accreditation in 2018. And of today, we've only been joined by one other trust within the UK, Nottingham Children's Hospital, which gained accreditation this summer. So we remain the only acute trust to hold this. Designation is earned by the organisation who demonstrates a commitment to creating a positive practice environment where staff feel valued because they experience job satisfaction, growth and development opportunities, respect and appreciation. Next slide, please. We decided to start on our pathway journey in 2017, at a time when as a profession we were facing huge workforce challenges. As you can see from the slide, reasons why nurses were leaving the profession generally, and in the right-hand box, the position of us here at NGH. Our vacancy factor was then 13.8%, with nursing midwifery staff leaving due to not feeling that they'd had a collective voice, feeling undervalued, and they had a limited opportunity to progress their career. So once we'd made the decision we were going to start our journey, we had to start putting forward a number of actions and collecting evidence, as demonstrated on the next slide. Not only were we required to submit information on our organisation, our staff demographic profile, and would you believe it, my CV, we also have to submit written evidence in support of the 6 pathway standards. And finally, to back up all the evidence that we're giving, we have to survey each and every nurse to ascertain whether the evidence we submitted depicted how the nursing workforce was feeling. Once the evidence had been submitted and survey completed, we had a 6-week wait for the outcome. And we're really proud that on one cold October morning in 2018, I received the call that we'd finally been designated. Next slide, please. This slide just simply reminds us of the 6 pathway standards that collectively support everything that we do. It looks to ensure that we have a good environment, a culture of learning, empowerment, inclusion, interprofessional collaboration, which supports us to provide the highest possible care we can to our patients. Next slide, please. As I've said, to gain accreditation, we had to survey our registered nurses. What we had to do was we had to ensure that we could meet the target of 60% of our nurses participating in the survey. 82% of our nurses chose to respond to the survey. Of the number who responded, 50% were expected to strongly agree or agree to the 28 questions that were included in the survey. 75% of the respondent sample must strongly agree or agree with at least 21 of the 28 survey questions. Here at NGH, it was absolutely amazing. 26 out of the 28 questions, we scored 75% or above. Real evidence of how our nurses reflected on working here at NGH. Next slide, please. One of the other things that we've really had to work on is to develop and embed a shared governance structure, and we've chosen to use the shared decision-making model. Wards departments are invited to develop their own councils to push forward the principles of shared decision-making. Some choose to work independently within one area, and others work collaboratively across a number of areas. Pieces of work are developed appropriate to their needs, and we have a facilitator who works part-time supporting them. And I have to say that our charity has also been fantastic in providing support and advice. Recent examples of what our international councils have been doing, just to give you a flavour, includes our International Council coming together to greet, support and help orientate the international nurses that have joined us during the pandemic. Whilst at the other end of the spectrum, our Shared Decision Making Council on Gossip during the pandemic have undertaken an absolutely amazing piece of work to upgrade and refurbish their staff restrooms, which are now just absolutely amazing and have the envy of many other councils. All councils report to our leadership council, and I'm grateful, as I've said, to the ongoing support of the charity who turn up at every meeting and give advice and support. Next slide, please. One of the things that's also really key is that we make sure that we have meaningful recognition for our staff. And although this started off very much within nursing and midwifery, it's now rolling out and supported across the remainder of the organisation. And here's just a few pictures of the recent recognition events that we've had. One of the things that we've done during the pandemic is we've developed Terrific Tuesdays. So every Tuesday, a group of us will go out and hand out some teacups and goodies to staff that have been nominated by other members of staff for going the extra mile. And whereas previously it was run for nurses and midwives, we now have a whole plethora of staff nominating, from medical record staff to porters to cleaners to ward administrators to receptionists. It's just absolutely amazing to see their face when you turn up with a mug for them. Next slide, please. So what does this mean to staff? And these are just a few words that over the course of the last few weeks, we've pulled from questions that we've asked. There are two on here that particularly resonated with me. One was, you simply matter. And secondly, PTE means power to do excellent things, not just pathway to excellence. Next slide, please. So I hope I've been able to offer you an insight into what pathway is and its meaning. And this slide offers some ideas of the ongoing benefits that we're reaping from being a pathway accredited organisation. We've already talked today around our registered nurse vacancy rate, reducing from 13.9% in June 18 to below 4% now. Our skill mix has improved from 66.7% to 70.7%, which is in line with the national average. I'm really pleased that we've been able to improve the registered nurse degree rate up by 15% in the last 18 months. And the fact that we have had pathway to evidence, we know that's attracted international nurses to want to come and work at Northampton General. And that's a conversation that the nurses that arrived in the middle of the pandemic from the Philippines told me. We wanted to apply to Northampton because you are a pathway to excellence organisation. Next slide, please. But equally, we all do this as well, not just for ourselves, but for the patients. What does being a pathway accredited organisation mean to our patients? I think these bullet points are self-explanatory. Well-informed, supported staff leads to our staff providing the best possible care for our patients. Next slide, please. And what about for the organisation? As I've said, we do remain the only trust within the UK to be designated. We are seen as a beacon site. CNO, after I called her that cold October day to tell her that we've been accredited, 2 days later, she was here congratulating us and being out across the wards and departments talking to our staff. And she remains in close contact with us. She's supporting 14 other organisations across the UK on their pathway to excellence journey. And she uses us as a beacon, and we're especially involved in supporting those other organisations on their journey as well. You may have also heard me talk previously about the increased opportunity that our staff have through being a pathway organisation to present at national and international conferences. Indeed, earlier this year, Moya Flaherty presented her pathway experiences at the ANCC conference remotely. We haven't also got to forget that also this gives us an opportunity to develop our new nursing, midwifery and AHP strategy. And that's currently under construction with our colleagues at Kettering, and we'll be launching that in 2021 and working together with Leanne and the team to look at how two organisations can become pathway accredited. Next slide, please. I want to highlight nursing midwifery assessment and accreditation. We've had this in place since 2016. It's an evidence-based tool to help nurses and midwives measure the quality of nursing care we're giving to our patients. Our nurses feel empowered, and using the tool, it helps both individuals and teams to see what they can do at grassroots level to improve the care they give to patients. It's also actively supported by Ruth May, our CNO. It's worth noting that whilst we recognise and value the contribution that nursing midwifery assessment and accreditation makes, we want to see this as a group we've included this within our group hospital quality priority action. We want to further extend this and build a multi-professional assessment accreditation tool, something which will sit alongside nursing assessment and accreditation. And the next slide clearly visually depicts the picture of the progress. Next slide, please, Kieran. This depicts a picture of the progress that we've made as we've continued our pathway journey, driving up our standards of care from May 16 to March 20. Next slide, please. So we have to maintain we intend to maintain our accreditation, and we have to reapply for accreditation in the summer of 2022. We've commenced our journey to redesignation, aiming to be the first UK trust to achieve reaccreditation. Noting as well that noting a key addition to evidence around our strategy is to optimise the inclusion of diversity and inclusion within the trust, and we have to make sure that this time we need to put evidence in around education. Next slide, please. As part of our journey, we will also make sure that we continue to maintain a national profile by mentoring other UK organisations. As part of our academic strategy, which we've just talked about, we want to see our nursing, midwifery and AHP research profile increased, and we want to be increasing our diversity and inclusion agenda. Next slide, please. We cannot, though, underestimate the real impact that COVID-19 is having on our workforce. However, I firmly believe that Pathway to Excellence is our lifeline to recovery. When we talk and do pathway activity, our staff are engaged and they have a real can-do attitude. We continue with our meaningful recognition, our Daisy Awards, our Cavell Star Awards, and our Terrific Tuesdays. We're continuing with our national profile opportunities, and whether that be through CNO presence to her forums, we're also contributing to NAME UK and the Chief Nursing Officer's International Shared Decision Making Council. Next slide, please. So I hope what I've been able to do is give you a flavour of what's happening in the organisation with Pathway to Excellence. What I'd like to just ask the board to do after listening, and I'm happy to obviously ask any questions, is to support our redesignation journey so that we are not only the first trust to have Pathway, but we become the first trust to achieve redesignation and continue to expand nursing midwifery beacon of excellence and leading the way to multi-professional excellence. Thank you.
Thank you, Sharon. I can't imagine that we're not enthused by that, and we're more likely to say you'd better not lose the accreditation when it comes up for renewal. That would be a bit of a problem. Anyway, comments Absolutely. And other questions welcome, but I you know, the case is clearly made, and the staff like it. It's brought up the standards, and these things do not happen by accident. They require effort and process. Simon.
Thanks, Alan, and thanks, Sharon. I think this is absolutely fantastic. I think it's a real jewel in the crown of NGH, a real fantastic achievement that it's there, and one that needs to be built on. I could talk a lot about it because I've had the opportunity to look a bit behind the scenes about it, but I think we need to make a big deal of our support for this. One thing I want to just draw out from that presentation, the shared decision-making councils. If Mark was talking about what does our staff survey say that we need to do, it would say that we need to give people more empowerment, an opportunity to make a difference in their jobs and give them local control to do the things that we want them to do. And we are worrying, thinking about, well, how do we do that? Well, when in actual fact, we've kind of already got a fairly powerful mechanism in place to do that, one that we need to support and drive. And so I've been talking to Sharon, we won't spoil the surprise today, about how we reinvigorate and further promote those shared decision-making councils, because they're real, I think, aren't they, Sharon, the engine room of some of the work that this programme allows us to drive, and giving people the opportunity to make those on the ground frontline improvements. We underestimate it and the impact that it has. People have been also making comments about virtual ward visits, and because shared decision-making councils are also something that you can do online, I wonder whether there's a way of actually board members getting involved in some of those shared decision-making councils and supporting them, because they can be done online, they can be virtual, and it'd be a way of connecting you all back to the front line and hearing the things that frontline councils are really bothered about. So I just wanted to put that out there as an idea and a way of, maybe even if you can't be physically present, you can still be at the heart of some of the debates that matter most to people who are providing frontline care.
Okay, Simon, thank you for that offer. I know, sort of just engaging, just listening to the broadcasts and the conversations that you do and Debbie does, and so on, is terrific at understanding what the staff are thinking about. And when you're getting 10% or more of your staff dialing into those as they happen, let alone the ones who listen later, it's all pretty good stuff. So anybody interested in joining in with those, perhaps you could contact Kirsty or Claire. That would probably be the route into that. Anything else at all on that, other than just universal support for Sharon's efforts and determination to deliver it? Okay, thank you very much, everybody. And integrated care systems, Simon.
Okay, so I gave a bit of a kind of warm up to this in my opening comments. I think probably only 2 or 3 things to say from the paper. The first thing the paper sets out is that just making us aware that we are on a glide path towards the next stage of our development of an ICS. So discussions are now very active in the system. Alan and I represent you assiduously at those meetings and are putting forward our view as to where we think we should go. But this really reminds you that this train is leaving the station, and we need to be an active and leading participant in the debates that are about to happen. The visioning workshop in December really is an attempt to bring together both the practical and the forward-looking. So the practical is, there's a great deal of work going on about, so how do you structure all of this? How do you make sense of it? Because we have to remember at the moment, ICSs are not a statutory body in the NHS. They have no right of ownership or direction over what we do. And so it's a collaborative of the willing. And until such time legislation exists to support that, that's what they will remain. Therefore, organisation is tricky, and we're bound even more together by our aspirations. And if we look at those aspirations that Northamptonshire has talked about before, there are 3 that keep coming back. The first is, how do we start well? This whole notion of what's it like to be a child in Northamptonshire? How do we want our young people to grow up? What do we want for them as they become adults? The second is how to live well, stay as well as possible for as long as possible. And the third is how to end well. And those are the great challenges, but we have to turn those challenges, much as we're doing in our group priorities work, into a series of things that we're actually going to do. So if we believe those things, what is it that we're actually going to do to make them happen? And I gave you an example of how in another part, collectively, they decided to invest in smoking cessation. I'd encourage everybody, if you can, to go and look at, because there is a rich source of data on this, to go and look at Public Health England's website and what's called the fingerprint data. The fingerprint data sets out the public health indices for an area and allows you to compare your area with others, and it allows you to compare your area over time. And it's quite powerful reading when you start looking at it. And I'd encourage, as we all hopefully get involved in thinking about the future, we reflect on what our challenges are, some of which are not surprising, others of which you may find more interesting to reflect on. So as part of our commitment to shared system working, this paper finally is appearing at every board in Northamptonshire, and it's asking for our support and endorsement and our commitment to the visioning work that is going to go on over the next period of time. And hopefully colleagues will both support it and, as the workshops come into view, want to get involved, because this is our collective future state that we're trying to design here, and it's really important that we all support that work. I'll stop there, Alan. Happy to take any questions.
Okay, there's a lot in there, but we have seen this before. We've been through it with the people from the ICS and so on. Happy to take any questions or comments. Not in this paper, but elsewhere. There's Chris Powell, who's leading on this work, just in his spare time from sorting out COVID vaccines, has asked for some non-exec directors to help to think through how we would wish to engage with this, and particularly how non-exec directors would wish to engage with it. So he's asked for a small group, and he's asked for the two co-chairs of the Collaboration Programme Board, which I'm sure they'll be happy to agree to. There's one of them here, but he's also asked for another one. I've asked Denise to do that, and she's happily agreed to contribute to that. And we'll have a matching nomination from Kettering, I'm sure, when their board meets on Monday. So there's only a couple of meetings involved, probably not much more than that, but we're coming back to the January board with more detailed propositions. And I don't see Rachel shaking her head, so that must be all right. Anybody else at all want to talk about that? No? Okay. You know, you get I'm sort of drawn into a little homily here, really, on how I view the world. And years ago, when I applied for a job, I had a load of words about what mattered to me. And they were about being strategic, about being focused, about being inclusive, collaborative, persistent, and consistent. And I think the ICS plan is about all of those. And we need to think really carefully about how we engage with, collaborate, and deliver on things that really matter. What would we really want this to solve? Because if it goes all over the place, it will not solve anything. So there is this absolute focus on what Simon described as the 3 stages, but obviously within that, you have to be really focused if you're going to get this to deliver. But it has great power to deliver on solve problems that everybody has been unable to solve on their own, certainly for 20 years. And that's why we're buying into it quite so enthusiastically. So, okay, closing items. We don't have any questions from the public. I'd just like to add my comments about Phil to the one Simon made earlier. Thank you very much for all your work over the time you've been with us. Phil, thank you for developing Bola. I'm sure she's delighted with that as well. We look forward to Bola giving us advice and guidance in the coming months, and we very much wish you well in your new role in the regional office. So thank you again for what you've done for us. Can I just record that the next meeting will be on the 28th of January at 9:30, and it will be the same sort of virtual approach on Zoom. And can I now ask you to pass the resolution that representatives of the press and other members of the public be excluded from the remainder of the meeting having regard to confidential nature of business to be transacted and publicity on which would be prejudiced to public interest? Nods will suffice. Good, thank you very much. Can I ask you to be back at 12:15? That is a